My name is Jeremy Patch, and I'm the Senior Director of Patient Programs and Education at ZERO Prostate Cancer. Our first session today is on technology, AI, and prostate cancer. It seems like a very timely topic. I'm excited for you to hear from our esteemed featured speaker, Dr. Joseph Shirk, joining us shortly. He is the Chief of Urology and Director of the Clinical Procedure Center at the Greater Los Angeles VA Health System and Assistant Professor of Urology at the David Geffen School of Medicine at UCLA. Thank you so much, Dr. Shirk, for joining us today. It's my pleasure to hand it over to you.
Right. Thank you, Jeremy. Very excited to be here today and to chat with all of you for a couple minutes this afternoon and share some of the things that we've been doing from a research standpoint and the things that are available to you from a patient standpoint with prostate cancer. The title of the talk is Technology and AI and Prostate Cancer. There's so much to talk about there that it's hard to fit that all into a short talk like this. But I'm just gonna highlight a couple of things for you today that might be particularly relevant in the way that patients understand their prostate cancer and in the way that surgeons and other folks planning various treatments might think about that and might leverage technology and artificial intelligence to help with that. All right, so if we think about this from a problem standpoint, so what's the problem that we're trying to solve with artificial intelligence? Well, if I can make a somewhat controversial claim to begin with here, every day there are thousands of complex operations, and this includes folks with prostate cancer, that are planned using outdated technologies that are hard to understand, even for experienced surgeons. And what do I mean by that? And why am I making such a broad, sweeping claim? Well, in the next couple of minutes, I will show you what I mean, and hopefully you can think a little bit like a surgeon would planning an operation. This is the problem. This is a CT scan from 1970. That was the first CT scan that was ever done. It was done for a brain tumor, and you can see the skull and the tumor here on the left side of the screen. When you look at the right side of the screen, this is a CT scan done in 2024. The way we're looking at this is almost identical. So we're still looking at various slices, meaning different points in space that we find in the human body, and trying to patch those all together to form a 3D picture that's more real life. And that's what we use when we think about these cases during an operation. You see the image on the right is maybe a little less grainy, but overall it looks almost exactly the same. So they're really, over the last 50 years, 55 years or so, there hasn't been this quantum leap in the way that we think about imaging for patients with various diseases. I had a video here that I'm going to skip over. I was going to have you, visualize an object that was CT scanned just like a surgeon. It's really, really hard to tell what you're looking at. I'm going to give you the cheat sheet here, but it's hard to tell what you're looking at it when you're scrolling through the image. It turns out in the end it was, let's see if I can advance this. It was a statue that some folks had CT scanned. Unfortunately, this is not advancing. There we go. It was this statue. Most people, myself included, couldn't tell what it was in the CT scanner at all. And that's because our brains are not designed to think about images in a way that really allows us to understand 2D images and translate those to 3D. So again, if I can summarize the problem, our CTs and our MRIs provide limited data that generates uncertainty in our mind. It's not how we're seeing things in real life. And then the secondary problem is, for instance, patients with prostate cancer, there's information that comes in from different areas that's silo. So you have your prostate biopsy results, you have your prostate MRI, you have your other health information, and all of those are in different areas where the surgeon needs to access those in different ways, and that also generates some uncertainty in planning. There are some tools out there right now that allow looking at things in 3D. So over here on the left, we see what I call legacy 3D diagnostic tools. Those use a technology called volume rendering. You can see the 3D image here. It almost looks like you took the inside of a body and molded it out of clay. Not particularly useful for operative planning. Over on the right here, you see something called a surgical navigation system. These are used a lot for brain surgeries, surgeries of the ear, nose, and throat, where everything's very rigid. So all those structures are fixed within inside the human skull, and some of these technologies are able to help navigate. Very different when you're talking about a structure in the abdomen or the pelvis that might move around, and those are very, very costly technologies. This is some technical data that I'm going to skim over, but There was a study done about 5 or 10 years ago that showed how surgeons don't necessarily have the best understanding of where a tumor is in association with the rest of the normal anatomy for a patient. So surgeons, all they were asked to do was to look at a CT scan with a kidney with a tumor on it, and then they had a 3D model of that kidney, and they were asked to place the tumor in the appropriate location. And in many of these cases, there was actually no overlap whatsoever between what the surgeon thought was the location of the tumor and where the tumor actually was. So it just shows again, and here's a visual depiction of that. The purple is the actual tumor. The blue is where the surgeon placed the tumor on the 3D model. And you can see a lot of these, are close, but some of them don't even overlap at all. So again, the human mind is not really designed to take a stack of images, put them back together in 3 dimensions, and then really understand that 3-dimensional model in their head like they would the actual human anatomy. So if we think about this in the context of prostate cancer, what are we looking for? What's important to patients with prostate cancer that would be undergoing surgery? For me, I call it a trifecta. There's 3 different things. So the number one is ensuring that all the cancer is removed. So you want the cancer completely out of your body, no positive margins, and an undetectable PSA. That's the blood test that we use down the road to determine whether that prostate cancer is gone or has returned. We want to maximize preservation of continence. And a lot of that happens with the way that we do surgery around the bladder neck. And finally, maximize the preservation of the nerves that are required for erectile function. Those help a little bit with continence too, but those sit really right on the back of the prostate. They're very, very delicate. So all of these things are in very close proximity, and the better understanding we have of where they are, the better we can achieve this balance here. So on one side, we have our oncologic outcomes. On the other side, we have what I call our functional outcomes, which would be urinary function and sexual function. Right now, this is what surgeons are tasked with understanding. So this is a prostate MRI over on the left. On the right, you see a biopsy report. I talked about these being siloed earlier. So these come in different areas of the patient chart. And I don't know about you. I mean, I'm an experienced prostate cancer surgeon, but looking at these MRIs, it's really hard to make heads or tails of where the prostate cancer is and what I'm looking at. And again, it's one sort of slice in space here. I'm looking at one small area of the prostate. The things that we're interested in looking at are the prostate, so that's this area in the middle, the bladder, the urethra, which is that tube that you urinate through that goes through the middle of the prostate, the seminal vesicles, the nerves that are posterior to the prostate, the masses that the MRI identified, and then the biopsy, areas of the biopsy that were positive for cancer, and those occur in different parts of the prostate gland. So the research that I've been involved in over the last 10 or 15 years is how do we take these biopsy results and these CT scans or MRIs and create 3D digital models for surgeons that allow them to understand the anatomy better and allow them to perform a better operation. And then on top of that, allow the patient to understand their disease a little bit better and make a better decision up front, whether they want to proceed with surgery or radiation therapy or active surveillance or any of the other options that are available. So this is sort of a diagram showing how all these things fit together. Artificial intelligence, machine learning, computer vision, those are all things that you hear about almost on a daily basis in the news now. We're really going to focus on computer vision, which is a combination of machine learning and artificial intelligence that allows us to generate these models. This is, again, a project that I've worked on for the last 15 years and some research that came out of UCLA. What I'm going to show you now is actually an FDA-approved software product that uses machine learning and artificial intelligence to create these models. As a disclosure, it is a company now in the Bay Area called ZERO that creates this 3D product. It's a product that's reimbursed by Medicare now and is in use in hospitals across the United States and actually globally as well. But just as a disclosure, this is something that I've been involved in for the last 15 years. What you see on the screen here is one of those models. I had a video that shows how you can rotate this and show and hide the various structures and look at the margins for the for the tumor, look at the biopsy segments. Those videos unfortunately aren't working today, so I'm just going to walk you through this model here. The structure in brown, the big structure kind of in the back, that's the bladder. The urethra is the tube going through the center of the pinkish structure, which is the prostate. The tumor is in sort of that deep reddish brown color in the center of the prostate. The seminal vesicles are the white on the back of the prostate. And then underneath the prostate in sort of that woody looking strip, those are the nerves. So those are the the essential functions for erectile and bladder function. Second, this was the video here. I don't think we'll be able to see that today, but again, it's another view of the tumor and the nerves and the interaction between those. This is a good way of looking at it without a video. So you see the MRI up top, you see the biopsy report here that shows where the cancer is. On the left in the bottom, you see the tumor, you see the nerve. And then when you remove the nerve, you can actually see a heat map of where that tumor contacts the capsule of the prostate. That's where it's in the closest proximity to the nerve. And that's where, when you're a surgeon thinking about making a decision, you might think about taking a little bit more tissue on this side of the prostate, maybe removing even a little bit of that nerve, preserving a little less sexual function, but making sure that all that cancer is removed from the body. And then what you see in this final image here is you see the biopsy segments on the prostate itself. They're color-coded, so the red is grade group 2, the orange is grade group 1. These are just different classifications for the Gleason grade, which is a measure of sort of the severity of the prostate cancer within the prostate. White means no cancer at all. So the surgeon has a wealth of information now at their fingertips. They're able to rotate and look at this model. They're actually able to look at it inside of the surgical robot live while they're doing the operation and compare what they're seeing live to that 3D model. So the question is, this all sounds great. Does any of it actually work? What we did to test that was we did a multi-site randomized controlled trial. This was a 24-month trial at 6 hospitals across the U.S., 15 surgeons. There were 92 cases. It was a 1-to-1 randomization. So patients either had their surgeon look at their MRI and their biopsy results alone, or they looked at the MRI results, the biopsy results, and the 3D model. The 3D models were digitally delivered to the surgeon's phone. The surgeon then plugged their phone into the surgical robot and viewed that live while they were operating. So these are kind of busy slides, and I'm just going to tell you that between the two groups, we didn't really notice any differences in what we call baseline characteristics. So the patients looked relatively the same. They had the same type of disease when you compare the two patients. Initial studies, we checked a couple different time points. So the 3-month PSA is one of our best indicators whether there's going to be disease recurrence in the future. We saw that there was a difference initially between the folks that had the model used for their operations and those that didn't. So the undetectable PSA, which is the perfect outcome, that was different at both 3 and 24 months. The other thing that we saw, it was lower. So undetectable PSA was actually 100% in the group that had the 3D models used. So no residual cancer whatsoever, which was great news. It was exactly what we were hoping to see. We also looked at those folks that were getting either radiation therapy or hormone therapy afterwards, and there was also a very large difference between the two groups. Only one of the patients with the 3D model needed to have that, whereas about a third of the patients without the 3D model needed additional treatments, and those are tough and potentially harmful treatments. For sexual outcomes, we noticed a difference at 18 months. So we noticed the SHIM score, which is the Sexual Health Inventory for Men. It's a measure of the erectile function after the operation. That was actually significantly different between the two groups that we looked at. So it was better in the group that used the 3D model. And then for urinary outcomes, this was about the same. So we didn't get worse, but we also didn't get any better when we were using the 3D models. So then, to summarize this as a slide, cancer control was much better. So the intervention group, which was the one where we used the 3D models, there were no patients that had a detectable PSA. There were much fewer patients, so 3% versus about 32%, needing additional therapies like radiation or hormone therapy. Erectile function was also different. So the SHIM score that we looked at was significantly different between the two groups. Urinary continence was about the same. And then we came up with a metric called a trifecta outcome. This is something that's described in a lot of previous studies, but those are patients, we describe this as folks that had an undetectable PSA at 24 months after their operation, did not require any sort of additional therapy, had erectile function that was equal to or greater than the function that they had prior to their operation. So they returned to their baseline. And then patients that were completely continent, so did not require any incontinence pads per day. And what we saw that there was, without the 3D model, About 10% of patients achieved that, and about half of the patients achieved it with a 3D model. So the takeaways here are surgeons are changing their plans. These are the things that we saw that were changed in this study. A lot of things around nerve sparing or around the margins that they're taking, around those specific tumors. So surgeons changing their plans and seeing better outcomes after the operation. These are the surveys that we gave actually, this is different. So this is a survey that was given to patients when they were coming into the operation, and the surgeon actually showed them the 3D model to help them as part of the decision-making process. And you'll see we did what's called a Likert scoring. So, these are your standard surveys where 3 is neutral, 5 is you strongly agree, 1 is totally disagree. And you'll see these scores are very high across the board. Patients really seem to get a lot out of the models for the decision-making process and understand their condition much better after looking at the models. Here are some of the comments from the patients from this study. So you can see we broke these down into a couple of different groups: better understanding of the disease, more confident and comfortable in the treatment. It's just really visually striking when you see this on a phone or an iPad to be able to spin your prostate around and see exactly where your tumor and your other structures like your bladder and your nerves and your urethra are. It's really an immersive way to take a look at this. So if we can summarize here, so this is just the tip of the iceberg. This is just one tool that surgeons and patients now have at their fingertips that our most recent studies have shown improve patient outcomes. So they allow surgeons to perform a better surgery. And in theory, they allow patients to better understand their disease and potentially even pick a better course of action when there are multiple good courses like surgery or radiation therapy or active surveillance. So AI is rapidly advancing the technology that we can use. This new technology provides surgeons with more information and patients as well. They may benefit from those decisions and have better outcomes as a result of those decisions being made and a result of their surgeons being able to perform a better operation. So that is all I have today. I hope that was insightful, and I hope there are some questions that I can answer.
Thank you so much, Dr. Shirk, for that great information. It was a really informative slides there. So we'll now turn it over to our audience questions. So please go ahead and drop those in the Q&A box if you've got questions, but we do have a few that have come in. So first question is the ZERO system, hopefully I'm saying that correctly, CEEVRA, widely available, or is it only available to few institutions?
Yeah, it's a good question. And again, I want to preface this again by saying I'm a co-founder of the company, and I don't want to give you any information, that would push you one way or the other. Obviously, I really believe in it. There are other systems out there as well. Intuitive Surgical has a system that's a bit similar. This is the one that has the FDA clearance to use AI and other things and incorporate that into the planning process. So to answer that specific question, it's available in about 40 hospitals and health systems around the country. There are specifics that we can get into. So there's West Coast programs, there's East Coast programs. There's a health system in the South, specifically Florida, that exclusively uses it. It is a product that is now reimbursed by Medicare as well. So if it's something that you're going to a hospital for your surgery and you ask them about it, it should actually be something that they have access to and can be reimbursed through the hospital system.
Okay, thank you. Is there any application of this AI technology in guiding local therapies, perhaps for other not just surgery necessarily, but outside of surgery?
Yeah, definitely. And that's a really great question. So focal therapy, the folks that do focal therapy fall into a couple of different camps. There are folks that will do either whole gland or hemigland ablations, which is less targeted. So therefore the need to pinpoint the exact tumor is a little bit less. And then there are the folks that try to just do a zone of ablation around the tumor. The company and the technology is working closely with a couple of those folks that do focal therapies to integrate it with their systems. There are some surgeons that are doing this, and I know of a handful right off the bat that don't necessarily have the model integrated with their ablation system, but always look at it before the ablation to kind of tell where that ablation zone is going to, where that's going to encompass, and what other structures might be in the way. So yes, definitely an application there.
It's an interesting question. With AI capabilities, and I think just, the new technologies and better targeting, will this perhaps eliminate the complete removal of the prostate and just the removal of the cancer lesion? Also kind of related to focal therapy, what you were talking about too, but.
Yeah, definitely. So that is a really, really good question that I don't have an answer to. So we've always treated prostate cancer a little bit differently than other cancers. So I also do kidney surgery. I can tell you the amount of times that I take the entire kidney out rather than just the tumor itself is very, very low. But for the prostate, we take the whole thing out. The thought with prostate is that even if you have a lesion that's seen on the MRI in one specific spot, oftentimes there are small pockets of prostate cancer elsewhere in the prostate. So it's microscopic, and you see it on the pathology later. And occasionally you'll find it with one of your biopsy needles, which is why the 3D models actually have those biopsy cores integrated so you can see where those are. But a lot of times those are missed. So it would take a leap forward in sort of AI and detection technology to make that happen. But nothing's ever off the table. There are some folks at Sinai in New York that are doing these partial prostatectomies now, and the jury's still out on whether that's an effective treatment for for prostate cancer in general. So people are always thinking about that, and this could be a tool to do that in the future. I'm just we're not quite there yet.
Thank you.
Jeremy, there's a good one here. If you don't mind me jumping in, can I pick one of these?
Yeah, go ahead.
Okay, so what kind of systems are there for metastatic prostate cancer? I think that's actually a really important question. Same system. So metastatic prostate cancer usually goes to the lymph nodes or to the bones. Once the prostate cancer is in the bones or some other organ, usually we don't advocate for surgical treatments. Usually that's maybe some radiation therapy or androgen deprivation therapy. However, we have a study that's open here right now at UCLA where we are doing what's called a radio-guided surgery. So patients with a few lymph nodes after a prostatectomy, what we're doing is we're going in and doing what's called a salvage lymph node dissection. And I've done 32 of these now on this trial. We give an agent the night before that's binds to the prostate cancer cells, but it also has a little bit of radiation that's associated with it. So it's a PSMA binding agent. That's given the night before, it washes in, it goes and binds to those lymph nodes, and then I go in the next day robotically, I take a very small probe that detects radiation, and I go find those nodes specifically. I also use a 3D model that's derived from the PET scan, because sometimes those nodes can be very, very tricky to localize. And if there's surgery done in that area before, everything can be very, very scarred and very stuck. So the combination of the two, we've actually been really successful at removing these nodes, keeping people off of radiation therapy, off of hormone therapy, which tends to have a lot of side effects. But there is a real application for a combination of a 3D digital model like this, plus something else to treat those metastatic cases.
And one of these questions, and you're not, I'm just gonna take a swing and see if you can help, but since you're not a radiation oncologist, but radiation is generally for localized disease, the other than surgery and a little bit of focal therapy, usually radiation is the other big one. So any applications for AI that might be able to help for radiation, like just in targeting where to radiate?
Yeah, so the radiation oncologists do things a little bit differently. They don't necessarily use this sophisticated of a 3D model. They do some 3D modeling. They do what's called a CT simulation, where they'll go in and they'll look at the prostate, They'll put a couple of small seeds in there and they'll use that for targeting their radiation. Radiation over the last 15 years has become much, much more targeted. It used to be a much broader field, but now it really is, it used to be proton beam therapy was the most targeted. Now almost all radiation therapy is very, very, very targeted. So it's a little bit different way of doing it. And they do have some AI algorithms that are running and helping them with determining the boundaries of the prostate and where to